Welcome everybody. So I want to first say that this talk is it's geared towards doctors. So if you get, I presented this exact talk a week ago at the American Academy of Neurology. So if there's any doctor speak that you don't understand, and there's a lot of gibberish in here, then just raise your hand and we'll talk about it. Because I'm not trying to confuse anybody. You coming here to get confused is not ideal. So what I wanted to present is that recently I was asked to talk about fatigue and sleep disorders in MS and how they affect patients with MS. So when I went to the American Academy of Neurology, this was kind of a review of the literature. At the bottom of each of these slides, there's actually the journal articles where I pulled all this info from. So it almost kind of reads like a talk that's like a review on a topic. So we'll talk about it, but if anything's a little bit too sort of confusing, just raise your hand and we'll talk about it, okay? And if anyone in Elko has a question too, by all means do the same, and they'll let me know that you're saying something. I can't see you, but is there anyone there? In Elko? Okay, there's people there in Elko. Perfect. So if you have any questions, somebody will let me know. And one of the things they always do, and this is something that we do now, so I'll just do this because out of habit, but when we talk about any kind of continuing medical education, we have to do disclosures. So I actually have worked with companies that would do multiple sclerosis. They make multiple sclerosis medications in various capacities, from research to education, these kinds of things. So that's what this means. It means that I actually have been employed by these companies as well, just to make sure you guys know that I don't have any bias. But with regard to medications, there's only one medication made by any of these companies that I'm going to talk about tonight, and it's an off-label thing, so I'm not going to sway you to buy anything that I've had anything to do with. So fair enough? So with regard to fatigue and MS, I think this is the key. Fatigue is really common. I mean, it's common in general, but it's really common in MS. Up to 50 to 80% of people. Sometimes it can actually be the most disabling symptom. And it often is one of the first symptoms, and it's something that is so non-specific. I mean, it can be caused by a ton of things that it's often missed. It's the way that it's sort of defined in the medical literature is an overwhelming sense of tiredness for no apparent reason, right? If you haven't slept for 2 days and you're tired, that's not a mystery, right? That's the problem. But it's this feeling of tiredness or lack of energy, or a subjective lack of physical or mental energy that doesn't really have a known cause. And then the other thing is that it should interfere with what you're trying to do, what you would normally do in a day. And if that's happening, then you need to do something about it, clearly. Sometimes people talk about it as a lack of motivation, physical and mental exhaustion, increased mental effort. Sometimes the fatigue is actually described more, not that they're tired, but the things that they used to be able to do easily are now harder to do. Like I used to be able to do math in my head really, really quick, and now it's just so exhausting to be able to get through a math problem. So when you really if you look at data across patients, what they'll say is up to 2/3 of patients will say that this is a big problem for them. And it's problematic for doctors for a bunch of reasons, but I'll talk about that in a second. It may be it's more seen in progressive MS, maybe. There's at least been a couple studies that have shown that. It seems to be worse by heat, and so this is a problem here in Vegas in particular, right? Heat is a problem here. It's a problem across the whole South, but it's a problem kind of anywhere. There's a guy by the name of Uthoff, an old German neurologist, and he described this way back when. In fact, back in the day, we used to take people with MS and we put them in a hot tub, and if their symptoms got worse, we called it MS. Because if you raise the body temperature either through a fever or through heat or through exercise, then the nerves that have lost myelin but are still intact, they actually get more symptomatic when you heat them up. And so part of that is because when a nerve has lost its myelin, it doesn't conduct as rapidly, but it'll just like in physics, and if you take a wire and you put it in heat speeds conduction. And it is the same thing on a nerve, but a nerve that's kind of functioning slow and then you speed it up, then it's going to bring out the problem. A way you can think about that is that if you go like on I-15 at midnight flows very well, but at 5 p.m. not so much, because you're sending too much information down too many cars down that little path too quickly. Does that make sense? So that's kind of what heat does to MS. So one of the things, so this is a bit of a segue here. One of the things that I like to I talk about often, if you've ever seen me in clinic, is finding ways to stay out of the heat. So this is something called, these are things that you can buy. If you go to the Multiple Sclerosis Association of America, which is just the MSAA, if you just Google Multiple Sclerosis Association of America or MSAA cooling, there's a application you can get free cooling equipment. You can get a cooling vest, you can get cooling bandanas, and they'll just send it to you for free as long as you have MS. But a couple other cheap things you can do This is something called Enduracool, and this is something called a frog Tog Chilly Pad. As goofy as these are, you can buy these at Dick's Sporting Goods, you can get them at Amazon.com, you can buy them at Zappos, you can buy them all over the place, okay? And what these things are is that it's a kind of a material here that, this is the Enduracool one. It just looks like a scarf almost, but when you get it wet, it's much colder. So what I have is this end is cold, is wet, and this end is dry, so you can feel the difference here. And they stay like that for about an hour or so after you get it wet. This one's a little bit of a different feel. This is the frog tog goofy thing, but it's actually a little bit cooler, but it has this sort of rubbery feel to it. And when you get it on this side, this is after about an hour. This for a couple hours will stay really cold, but it's a little bit more moist. And the thing about this is that you can stick these in a purse, you can stick them in a bag, and you can actually kind of feel the difference of what they feel like. It's a little bit more moist though. But it's an easier way, and these are about 10 or 20 bucks, and they're cheaper, and it might be a way to get out of the heat in a pinch. If all of a sudden the energy goes out on your house and it's 100 degrees out there at night and you have no way to cool down, you could take this. You don't even need it to be cold water. You can just dip it in warm water. And what it does is it evaporates and it keeps you cool. So that's something to think about. They're cheap and they're easy fixes.
What's this one called?
That one's called Frog Tog. It's F-R-O-G-G-T-O-G-G. I didn't name it. That's what they're called though. But these are things that I've had. I actually was first introduced to these at an MS event where people were giving them away as prizes. So they're just things that you can use, cheap, easy ways to try and stay out of the cold. Also, exercising in a pool helps if you have access to a pool in the heat because it keeps your body temperature down. Sometimes this fatigue is worse as the day goes by. It sort of seems to negatively impact a lot of aspects of life, including finances. Sometimes people can't work as long as they used to. It actually can endanger their finances. Another odd thing too is that if you're ever applying for disability, fatigue is actually something that is recognized in MS. So if somebody like your doc is filling out disability paperwork and they put in fatigue, that's actually helpful because it is limiting and it's recognized even by the government as being so. The other thing is odd is that it can be very acute, like in the middle of a flare. You tend to get more fatigued. It could be intermittent and it can be chronic. So just to talk about pathophysiology, which is sort of how we think this fatigue is being caused. Not surprisingly, it's not completely understood. And I think that the reason it's not completely understood is because there are a lot of different things that can cause it. So conceptually, I'm going to try and divide it up into two different things. Primary fatigue, which we think is fatigue due to the actual illness. And then secondary fatigue, which is fatigue due to something else that's also going on. One of the sad truths about life is that just because you get one disease doesn't mean you can't get another one, right? There's no like quota for diseases. So oftentimes it's other causes that are the thing causing fatigue. I had a lady came in just about, 2 months ago, 3 months ago, and she had just unbelievable fatigue. And we just looked for the regular causes of fatigue, and it turns out she had incredible iron deficiency anemia. We gave her iron pills, energy way better. Nothing to do with her MS. She does have MS, but that was not the reason for her fatigue. So that would be a secondary cause of fatigue that we can actually fix. So the primary fatigue is thought to be due to these kinds of things, and I'm going to talk about these a little bit more and what they mean. And then the secondary one would be any of these things: depression, some other illness, infection, hypothyroidism. We get a lot of the thyroid thing happening. People just, their thyroid's not working. Also, I mean, in all honesty, a lot of the medicines we give people to treat other MS symptoms make you really tired. So that's a problem. And other things like heat and humidity, right? And if you live in Florida in the summer, forget it. It's just brutal down there. So when you talk about, so I'm going to talk about primary. So see these like this list. I'm going to kind of go through these and explain a little bit what it means. So this decreased CNS reserve, the central nervous system, this is a concept which means that in multiple sclerosis there's inflammation, and there's the myelin is taken off, and there's actually destruction of some of the nerves. So what happens is that in order to perform a similar activity, if you take somebody with MS and somebody without MS, you ask them to do the same thing, the person with MS has to burn more energy to do the same task. Does that make sense? They're just less efficient with their use of energy. There are studies that show something called resting functional MRI. And a functional MRI is one of these MRIs where you lay down, they're doing the imaging, and they ask you to do some task like, count backwards, identify some pictures, something like that. And then they actually see where the glucose is being used, where you're using energy, and you can visualize it. And when you're doing a resting functional MRI, all you're doing is saying, just lay there, and we'll just look at your MRI and just see where the glucose is being used. And people with MS, just at rest, are burning more sugar in their brain than people who don't have MS. So they're just using more energy, and it's a lot less efficient. And so as a result, you can get exhausted. You're burning through your energy quicker, right? It's almost like a brand new iPhone from like a 3-year-old iPhone. The 3-year-old iPhone, the battery dies much quicker, even though, you know, it's ultimately operating the same system, right? So the other thing too is that, you know, we often talk about like these lesions. If you ever see an MS doc, we often look at the MRIs and we look at the little spots in the brain. And we try not to get too caught up in the spots, but one of the things that this correlates with is the more spots you see, the more people tend to be fatigued in general. And a way to think about that is that, remember, the brain is sort of a network. And the signals are trying to get everywhere. They're trying to talk, this guy's trying to talk to that guy, this guy's trying to talk to that guy, and they're trying to do it as quickly as humanly possible. But again, similar to like, say, the Vegas analogy, if you think about I-15, if you're driving on I-15 on a regular day at like say noon, it's probably okay, but they drop a lane, maybe there's a car accident here, and then maybe this cop pulled a guy over here, and then maybe there's a big rig that pulled over here, and then somebody else dropped off forget it. The place it's a wreck, right? Nothing gets where it needs to go, and it's much more time consuming. You burn more energy, you actually burn more gas doing that, and you're more exhausted by the time you get home. And in a similar way, the more traffic jams you throw in that brain, the more difficult it is to be able to do whatever it is you want to do. All right, so we want to stop these lesions from forming. The other thing too is brain atrophy. It's a sad truth, but actually our brain peaks in volume at 21. So after 21, it's all downhill. Just sad but true. That doesn't mean you know the most at 21. Just means, I think it means you think you know the most at 21. But at 21, so our brains, all of our brains are shrinking at a very low rate, like 0.1%, 0.2% a year. But in MS, it's more rapid. It's something like 0.6, even up to 1.2%, depending on the trial. So it's anywhere from like 3 to 4, maybe even up to 10 times as quickly. So one of the things that we have been trying desperately to do in the MS world is find ways to stop that. But the more the brain sort of shrinks again, the more fatigued you're going to be, because there's less brain there to do the job, right? If you have 3 people doing a job, it's easier. If you now have 2, then you got more work, and so it's harder. So immunologic factors. During an MS relapse, fatigue is increased. And that's due to a lot of these inflammatory markers. The interferon beta, these are things like your beta-seron, your Avonex, your Rebif, Extavia. Those medications, they increase fatigue as well. So part of what we do when we give people medicine to treat it, we actually sometimes make that fatigue worse. TNF-alpha is a chemical that your body makes in an acute inflammation. These chemicals, and there's a whole list of other chemicals. These are cytokines that your white blood cell creates that makes you fatigued. You ever get a flu, right? I mean, one of the first things that happens when you get a flu is you're exhausted. You're just so tired. And you get warm and you just feel really ill. So when your body is inflamed and your immune system is getting activated, it emits these chemicals, and these chemicals make you tired. And so the same thing is happening in MS, right? When you have an inflammatory condition, the same thing with lupus or rheumatoid arthritis, any of these autoimmune conditions are going to give you fatigue due to this similar mechanism. So this is happening on some level in everybody with MS. Neuroendocrine has more to do with this whole pituitary, hypothalamus, cortisol, adrenal gland sort of area, right? So and the reason this is important is that in rheumatoid arthritis, when your cortisol levels go up, and cortisol levels go up when you're stressed, they go up in people who have rheumatoid arthritis. When the cortisol levels are higher, they're more fatigued. In chronic fatigue syndrome, when it's not working as well, people are more fatigued. So there's something there. And the only reason we think that has something to do with MS is that one of the medicines that people use a lot of is this thing called Modafinil, otherwise known as Provigil. You guys have heard of this one? Mm-hmm. So that one works, we think, by increasing the activity of this axis. It sort of increases the activity of the hypothalamus and the pituitary, we think. So there's something to do here as well. And I'm not going to get into too much detail other than to say that we think that this is how some of the medicines that work seem to work. Sleep disorders. I'm going to talk a little bit more about this in a little bit, but basically 50% of people with MS have some problem with sleep, and that can be, it's highly varied, and we'll talk a little bit about it. But if you're not sleeping well, you're going to be tired. That's just the fact, right? If you ever talk to any doctor who's been through residency, they'll tell you that's true. Because if you are denied sleep for 48 hours, you just don't think well, you don't act well, you don't work well. So this can be caused by a lot of things, right? Depression is also a real issue. Every once in a while, patients come in and they have all these symptoms, and I just start talking about, like, are you sad, are you crying? They're like, look, I'm not crazy. And I agree. But the truth of the matter is that people who have depression, 50% of any MS patient, 50% of patients at any time with MS have MS. I have depression, so I'm talking in circles. 50% of people with MS at any given time have depression. And so this is something that we really want to take seriously, and when you are depressed, you're more fatigued. And there's been studies to show that treatment of depression by itself improves fatigue. There's also studies that have shown that if you don't treat the depression, fatigue doesn't get better. And there's a lot of reasons for that. But you know, when you feel awful, then that makes you more depressed, which makes you feel more awful, which makes you feel more depressed, and it's this nasty cycle. So as soon as you can break one of those things, you actually do a little bit better. MS medication effects, we talked a little bit about, like interferons, but also all these other medicines. If you've got spasticity or tightness in your muscles, we give a medicine called baclofen or tizanidine, and that makes you tired. If you've got burning, tingling pain, we give medicine like Lyrica, or we give gabapentin, and that makes you tired. If you're kind of feeling kind of sad and down and you've got burning, we can give a medicine called a Tricyclic Antidepressant, and that makes you tired. Also, if people have anxiety or jumpiness or legs that are twitching, sometimes we give medicines like Valium. Those make you tired. So whenever you have a lot of fatigue or other issues, and this goes for sort of any neurologic condition, you have to take a look at the medicines that you're taking and say, what am I doing to myself? Am I making myself more tired? In the allergy season, if you're taking a lot of Benadryl, you're going to be tired. It's just the way it works. So we have to be careful. And the heat and humidity definitely make things worse. The exposure of an environment is also something you can't really miss. I have one of my patients who's a line cook, and she sits over a hot stove all day long. That makes her MS way worse. It's tough. So it's one of these things where you have to be, you have to pay attention. If you work in construction out in the summer, that is brutal in this city. Now if you're out in Wyoming, not so bad, but it just depends on where you are. Long hours is another issue as well. So if you're looking, if you're working, shift work sleep disorder is something we see a lot in this town. These are people who work like, 8 to 5, and then the next week they work like 4 to 12, and the next week they work like 10 to, 6 or whatever. That is its own problem, and it turns out there's FDA-approved medicines for that kind of fatigue, and it turns out that it's Modafinil, which is that one that we use a lot in MS. Now I'm going to talk to you a little bit about that medicine in the future in just a few minutes, but every medicine we've ever tried to treat fatigue in MS has failed. Every single one has failed in trials. So there's no FDA-approved medicine. There's no silver bullet to MS, and that is the big problem. This is why they ask people like me to go to the American Academy of Neurology and teach people how to deal with it, because there is no silver bullet. You can't just reach in a pocket and hand somebody a pill and they'll be better. It just doesn't work well. And a lot of it has to do with what we're about to talk about next, which is secondary fatigue. There's so many other causes of fatigue that you have to rule out before you start throwing medicines at the problem. So the first one is comorbid medical conditions, which means a medical condition that you have at the same time as your MS, right? So you have two different things going on. Fatigue, people who smoke can have emphysema, anemia, infection, hypothyroidism, all kinds of things like that, sleep apnea. These are all big issues that occur very commonly that will happen in MS patients. So this was actually through a reference website, and this is what the general medical community has recommended in somebody who presents with MS but has fatigue. So you just send these labs. You're looking for iron, you're looking for inflammation elsewhere, you're looking for things like anemia, you're looking for things like glucose and sodium and potassium. Are those things where they need to be, right? Thyroid, is that okay? And also sort of muscles. And sometimes muscles lead to kidney issues, which also can cause fatigue. So you just take a look at these and see if they're okay. And it's just a blood draw. And if they're there, then you can attack those. There's a lot of different ways to try to assess fatigue. Most of us as doctors just ask about it. Do you have fatigue? And then we ask a bunch of questions. But it turns out there's a lot of these standardized kind of scales. This is a list of the scales that were used that are used in clinical trials. And when you look at them, they're kind of funny. This is what they actually are. This is the Epworth Sleepiness Scale. So if you look at this, what you do in that bottom, if you can see that bottom area down here. Sorry, I'm going to step away for a second. So if you look down in this area right here, what you'll see is that you basically just answer those questions. You score them from 0 to 3. So I don't know if I don't have an arrow or anything. But if you score, so the question is, do you fall asleep? Do you have a moderate chance of dosing when you sit down to read? What about when you watch TV? Do you fall asleep every time you watch TV? Look at this. If you go down about 5 or 6 down, when you're sitting and talking to someone, do you ever just fall asleep in the middle of the conversation? I mean, that's somebody who's really tired, right? And so the question, then you basically do a score. And if you're over 12, that's a problem, right? And what's funny is that, as a doctor, as a resident, every one of us who's ever done medical school or residency will be able to tell you that as a resident, you score really high on this scale. But a lot of my MS patients score high on this scale, and they'll tell me these things. And so, yeah, and a lot of times the complaint isn't, I'm tired. The complaint is, oh, my memory is terrible. I can't remember anything. Well, yeah, if you're falling asleep in the middle of conversations, you're not going to remember what was being said, right? Because you're tired. Anybody who's really tired can't remember anything. If you ever sat through a lecture in college with like the blue screen of death, you know, and they drop the lights and you're in those comfy chairs, like you're not going to remember anything from that lecture. You're going to fall asleep. So this is a scale that you can use. This is a little bit of a larger one. It's called the Fatigue Severity Scale. There's another one called the Visual Analog Scale, and they actually have these sort of standardized scores, and you can just download these off of a website. I just downloaded them right off the web. I just Googled the name of it and just found it. And you can score yourself, how am I doing on fatigue? This is a more complicated one. It's called the Modified Fatigue Impact Scale. And you rate it from 0 to 4 on these 21 different aspects. And you know, it's all, the score is 38, so you can actually score pretty high and still not be significantly fatigued enough for somebody to intervene upon. Because we all, you know, I have a one-year-old at home, so I'm kind of frequently in the moderate range of tired. But that doesn't mean there's anything pathologic. It just means my one-year-old needs to grow up, right? So it's one of these things that just happens in life. So when you're trying to assess fatigue, right, this is what you do. You identify fatigue as a problem. First of all, you have to identify it. Like, this really is a problem for me. Then you have to, you know, as a doc, we have to perform a history and physical. We have to figure out, is there any other cause, right? And that's where you got to, you know, determine if is it new, is it old, and if there's any other signs or symptoms of something else we could latch onto that we could attack. Is it a thyroid problem? Let's give you some thyroid. If it's an anemia, let's figure out what's causing that. And then determine if it's due to something like a respiratory problem. Is it maybe there's a sleeping issue, a sleep apnea. We'll talk about that again. If it's thought that all those things are ruled out, then you have to think about, well, if it's just from the MS, which can happen, what do we do next? Okay? So then at that point you start a treatment plan. So the treatment of common secondary causes, now this is a graph written by a review paper, and basically what they said, this is me adapting it. And if you think about what's causing fatigue and sort of what are the risk factors of more fatigue, some of these things you can't really change. I mean, old age, not much we could do about that. Your level of disability is tough, disease duration, form of MS, female gender. I mean, I don't think if you have even the surgery, I don't think that helps. So sleep quality and depression are things that we could actually go after. I mean, we can go after those things. So this is kind of part of when you're dealing with MS in general, neurological disease in general, but also when you talk about fatigue, is that you gotta focus on what you can fix and do whatever you can to maximize that and not worry as much about the things you can't fix, because there are certain things you just can't ever change. So management of fatigue, it's really correlated with depression, and if you don't get rid of the depression, you're not gonna do better. So then the question is, what do you use, right? So when it comes to sort of MS, it's not like there's a magic antidepressant like this one's better for MS than any other antidepressant. But here's the problem. A lot of these antidepressants will cause weight gain, like 10 pounds of weight gain. And if somebody's really, really tired, you don't want to attack 10 pounds onto their backs and have to carry it around all day. So you should think about that. The other thing is these TCAs, which is called a tricyclic antidepressant. These are the old school ones. Have you ever heard of them, like nortriptyline or amitriptyline or disipramine? If you've never heard of them, don't worry about it. But these medicines will make you really tired as well. So you have to be careful with that. There's a new group of medicines out there which you've probably all heard about, things like Cymbalta or Effexor or Savella. They put them on the TVs, you may have heard of them. They tend to be a little bit less tiring, and they're antidepressants that can also help with pain, and they can even sometimes give energy to people. In fact, one of the problems is they can make you an insomniac because they give you so much energy in a small percentage of people. But those are ones you could consider. The other thing too, and this is going to sound goofy, but therapy, talking to a therapist is very, very helpful. Things like cognitive behavioral therapy, supportive expressive therapy, there's actually good evidence in the literature that helps. You know, if you tell somebody you just need to talk to a psychologist and it'll make your fatigue better, they generally look at you like you're insane. But there's very good data that that's actually true. Pain, there's medicines, physical therapy, sleep disorder, we're going to talk about spasticity, other issues. So the reason I put this up here is because one of the big problems in MS is that people wake up, and the reason they wake up is because they're stiff or their legs are spasming or cramping or twitching all over the place. And that is not really a sleep disorder as much as it is an MS symptom that's waking them up all the time. So you have to address that symptom. And the other one too is this bladder issue. I can't even tell you how many of my patients get up every hour to hour and a half all night long to pee, right? Imagine that. That is a lot of disruption. And like I said, I have a 1-year-old at home, and with the baby, you get up about every 2 hours because they're crying, and I can tell you that is exhausting. And people tend to sort of get used to it, but that is not okay. So one of the things that we often do, and this is recommended by the National MS Society, is that at least once in your lifetime, if you have MS, you should see a urologist. You should be evaluated by a urologist and get a workup as to what's going on with your bladder, because 70 to 80% of people are going to have some bladder something, and that's going to affect probably their sleep, which is going to affect their quality of life, lead to depression, all kinds of badness. Not to mention the fact that it's kind of socially isolating. You never want to go anywhere if the first thing you have to do is figure out where the bathroom is, right? And that's a problem. I don't want to get too personal, but my mother actually said that when she finally saw a urologist, it was the best thing any doctor had done for her in years. She hadn't gone to a movie in like 7 years because she couldn't make it 2 hours before going to the bathroom. But now she can, so she can go to movies again. So it actually became socially liberating for her because she could go out and do things that she couldn't do before. Not to mention the fact that she could sleep through the evening, which, oh my gosh, so much better. So other things, so treatment of common and primary fatigue. So I'm just going to talk a little bit more about, there's 2 goofy things here, which are very intuitive, but again, they're helpful. There's this thing out there called energy conservation management, which is actually it's a very sort of regimented and well-described intervention, usually implemented by occupational therapy, but it's really intuitive, right? If it's designed to promote positive attitude focused on decision-making and optimum use of available energy. Sometimes what I say to my patients is that they are kind of on an energy budget, right? If you only have $100, everyone gets that. At the end of the $100, you're toast. So you have to budget where you spend that, right? You can't go buy like $90 shoes and then have $10 to eat for the month. It doesn't work very well. But sometimes with our energy, we tend to do that, right? Imagine how much, if you're one of these guys that gets up and goes to the bathroom every 90 minutes, all day long, that is an enormous waste of energy. And if we could just control the bladder, now all of a sudden, you've got all that energy to do other things with. You can go to the park, you can go paint something, you can go cook dinner, you could do whatever, something else with that same amount of energy by just redirecting it into something more focused and more productive. So it's identifying the development of activity modifications to reduce fatigue through analysis of what you do, like what do you do in a day and where are you wasting energy. It's kind of like a systems improvement process that businesses go through. Like, this is ridiculous, get rid of that, this is lame, get rid of this is terrible, get rid of this, but we're doing it on a personal level. Like, you waste your time doing this, don't do that anymore. And there's good evidence that this works really well. There's another one called exercise training, which is even more counterintuitive, but somebody who's really, really tired, you tell them, go exercise and you'll feel better. But it really is true. And if anyone has ever known anyone with fibromyalgia or chronic fatigue syndrome, there's very, very good data to suggest that when you take somebody who's extremely tired and you make them exercise, they feel better, which is counterintuitive, but it actually, when you understand what's going on, it isn't. When you are active, it has an anti-inflammatory effect. It activates the hypothalamic pituitary axis. It increases levels of chemicals in your body that wake you up. And it also makes people happy. And this, people who exercise, their depression goes down. So in general, exercise is a good thing. That old thing like eat healthy and exercise, it really works. So when you talk about exercise training, this is usually implemented by physical therapy, and it's more of a planned, structured, repetitive physical activity. And the idea is to improve your functional capacity. And this can be things like cycling, walking, yoga. And in this city, we're very blessed. We have 2 free yoga classes if you have MS. You can just sign up. They're funded by the MSAA. Just go on their website and you'll be able to find a free yoga class. I think there's one up in the north and one down in the south. So you can go to that. And if you do it, it really helps with your fatigue. And this is, I won't go into this in any detail, but there's lots of reasons why we think this helps. And there's evidence on every one of these levels that exercise helps all of these things in MS. So it's a really, if you're thinking about a silver bullet, that's the one. Get up and start moving, right? So it helps all of these things in clinical trials. All those symptoms kind of get better. And the other thing too here, if you bottom here, in one of the studies, it wasn't people who were severely disabled. Even in mildly disabled people who just were struggling with a little bit of fatigue and some symptoms, they even got benefited by just exercising more. And I can tell you that some of my patients, rarely, but I'd say a few % of people, when I tell them this, they really take it on and they really get in there and they start exercising, get a trainer, change their life. They always do better. You do better. People do better when they're really taking care of themselves. So these are the medicines that have been tested in large trials for the treatment of fatigue and MS. So I'm just going to go through them really quick and just talk about it, but just short and long of it is none of these really worked that well. But there's one that's kind of odd that I want to talk about. Pemelin is this medicine that it increases dopamine, which if you know anything about Parkinson's, that's where we think a lot about dopamine. But two small studies showed not very impressive results, so it was kind of abandoned. Amantadine is one that people have probably heard about. This is a medicine we give for the flu. It's also medicines that we give for Parkinsonism because, like Pemelin, it has these dopaminergic effects that sort of helps with tremor and that kind of thing in Parkinson's. In theory, there's been a couple small studies that have shown a little bit of benefit in fatigue. People just sort of feel better. A big review of all the studies, though, however, said that the evidence is insufficient to recommend it as common practice. And I can tell you that in my experience, it's never really helped a ton. It helps a little, but not really. And it has a lot of other goofy side effects: dizziness, nausea, insomnia, that kind of thing. So it's not like it's not like a free lunch, right? You can't take and just get energy, but you're actually there are some risks to it as well. And there's also some, if you have seizures, arrhythmia, heart failure, that kind of thing, it's a problem. In fact, any of you guys ever watch the TV show House? You guys watch House? So remember, like the third season, the girlfriend died in the bus accident. This was the drug. Never mind. That was a very obscure pop reference, but anyway, the whole thing, they figured out at the end that she was taking Amantadine, and that's what ended up killing her because of a weird side effect after the injury. I don't know why I brought that up. So my whole point is that it's not without its own side effects and problems. L-Carnitine is a much more benign thing that people try. You can get this at like a health food store like GHC. You can get them at Smith's or Walmart. And there was one study that showed that if you have low serum carnitine and then you give it to those people, they actually had better fatigue. Their fatigue was improved. Carnitine is one of these things that feeds into our mitochondria. I don't know if you know much about mitochondria. Think back to like biology in 8th grade where you had to make that human cell, right? The mitochondria is the part that generates the energy, right? So the mitochondria in this cell is what generates the energy for the cell. And so the carnitine feeds into that to help it to generate more energy in the form of like ATP, if you remember that. If not, that's okay. But the idea is that it's supposed to somehow feed into your natural fuel-making mechanisms and then help you to make more energy. There was also one study that showed that L-carnitine versus amantadine showed superior improvement in fatigue. However, again, when you look at the data across trials, it really isn't all that profound. It's cheap, it's easy, but it's not going to hurt you, but it's not going to be a big profound hit.
We know we lose mitochondria as we get older.
Right.
Our MS patients, has there ever been a study to show that their numbers of mitochondria per cell are lower than those that don't have MS?
I'm not aware of that, although one of the theories that's happening, one of the theories that we're working on in the, as a community in the brain is that it's mitochondria failure. And so the idea is that it's an energy failure leading to the brain injury. And there's ways, they're looking for ways to try to improve that. That's where you get the coenzyme Q10 coming in and the L-carnitine and this sort of thing. I'm not aware of any study that demonstrated that if you take like a muscle biopsy of somebody with MS versus somebody else, or a nerve biopsy, that there's actually a different amount. I'm not aware of that. But there's have you ever heard of the Terry Wahls diet? You guys ever heard of that? In fact, if you look at her book, I think it's called Minding Your Mitochondria. I think her entire basis of her whole theory is based on supporting the mitochondria in its energy promoting function. So there's definitely talk about this. I'm not aware of that particular observation though. I don't know if that answers your question. But it's something they're thinking about. I mean, if we could find a way to do that, it'd be great. Aspirin is a weird one. So here's the story. There's a guy named Moses Rodriguez who's a brilliant physician, and he is a researcher at Mayo Clinic. And he noticed in one of his patients that when they were taking high-dose aspirin, their fatigue was better. So because Moses is so brilliant, he got all of his colleagues to do a trial, and it turns out that it worked. So these people got better. Their fatigue was better. Another group, I didn't put it in this one. Another group replicated that recently in 2012, and it again was better. But you get this, the first study was in 20 people or 30 people, the next one was in 50 people. So these aren't big trials. And the problem is if you're going to be taking 1,300 milligrams a day of aspirin, you're going to get an ulcer at some point. Not to mention that it can be hard on your ears. So it's not a good long-term treatment. But it's an interesting, the reason it was interesting scientifically is what on earth is aspirin doing that's helping people feel better? Maybe we can isolate that. And it's thought that it's due to this hypothalamic pituitary axis that somehow is promoting that, similar to modafinil. But this is one that's out there. So if you hear about aspirin, it's 2 full aspirins twice a day. So it's 4 aspirin a day, which is a lot. And so I would not recommend this, but it is something that has shown efficacy in 2 trials now. 4-aminopyridine is what you guys probably know as Ampyra. Heard of Ampyra? It's been FDA approved for the use of walking in MS. So people who walk slowly, when they take Ampyra, about 40% of them will walk faster. They'll actually utilize their energy a little bit more efficiently. Based on that observation, it was thought, well, shoot, if it does that, shouldn't it also help with fatigue? Unfortunately, it didn't work. It just doesn't really work. And I think part of this is when you look at these trials, there's so many other things that factor into fatigue. I mean, are they doing sleep studies on everybody and ruling things out? And the answer is probably no. So I think part of the issue is that when you try these medicines, they're just throwing it at anybody with fatigue, but there's all these other causes. And if somebody has iron deficiency anemia and you give them this, it's not going to help. What they need is iron. So what they really want to do is put this down on people who have nothing but fatigue from the MS. And I think it may work there, but hard to know. Modafinil is the one that we probably use the most in clinical practice, but not because it's FDA approved. It's completely off-label. It's got the modafinil, the Provigil is 100 or 200 milligrams, and it's now generic, although the generic's still like $500 a month. It's insanely expensive. There's a new one out there called the RN enantiomer, just means it's a variation of it. It's a more purified form of the modafinil, and that's called Armodafinil, otherwise known as Nuvigil, because it's the newer version of Provigil. And that one is, again, like $800, $900 a month. And they work fairly well. They do. I mean, they work fairly well. In fact, if you get online and you start Googling it on it, you'll actually find that there's all these reports that President Obama uses it, that Air Force pilots use it. I mean, who knows if any of that's true, but there's a lot of sort of buzz about this particular medicine in the MS community if you start looking it up online. So what it is it's a non-amphetamine stimulant believed to increase cortical activity in the brain. And it's thought to do that through that whole HPA axis thing by affecting the hypothalamus and the pituitary to somehow increase your energy. It's FDA approved for 3 things: narcolepsy, excessive daytime somnolence for obstructive sleep apnea, and then shift work sleep disorder. Okay? So those are the things that if you happen to have one of those, we can get it for you. Otherwise, it's really expensive and hard to get. And it can cause headache, dizziness, nausea. There's some people who just cannot take it. They take it and they get really, really jittery and they don't like it at all. But it has been shown to show modest effects in 2 studies on MS, but not to the point where the FDA has said, yes, you can get an MS indication. So technically it's off-label, although it's one that's used often. Yeah, question? Yeah.
I have a friend and a daughter with MS. My daughter likes heat, can't stand the cold. My friend's wife can't stand the heat, loves the cold. They moved back to Marquette, Michigan. Is that a good move for her or not? Is it extremely cold weather like that? Or?
As far as one, so I guess this is what I would say, the heat, so the question is, some people like heat, some people like cold. Is it good to move to one environment or the other? And I think it all depends on the individual. And it also, you have to remember that we can now, with technology, control our environment pretty well. If you live in Vegas, you can still live in 76-degree weather if you like, just don't go outside, right? But you can do that. And so it's not that you have to live in one place or the other. There are certain places that are easier. I mean, if you could live on like coastal California and like the Central Coast, it's like 75 degrees all year. Yeah, but it's also $1 million for a 2-bedroom house, so it's tough, right? So there are places where you can do that. If you live in Florida, it's really muggy. If you live in Michigan, it gets really cold. I mean, there's no really ideal place for these people to be. I think the bigger issue is finding what's good for that individual. And I would honestly say that it's better to be around support networks and friends and family than to pick it based on environment. The other thing too is why some people like cold and some people like heat is unclear. When it's heat, most people don't like heat because it brings out their symptoms. But when somebody's had a spinal cord lesion in their body, you have to remember that any information your brain wants to receive from your body has to go through the spinal cord. And anything your body wants to tell the body, or your brain wants to tell the body, has to go through the spinal cord. So it's a little tiny area. So that would be motor, moving things, sensory, receiving information, but also all that automatic stuff, right? Nobody thinks it's hot, I should sweat. In fact, I'm going to sweat right here in this region, right? Nobody does that. We just do it. It's an automatic response. And we're doing it based on information that our brain is receiving, computing, and then saying the body is heating up, cool it down. In a similar way, nobody thinks I should, I just ate a big lunch, I should push that through my colon. Nobody does that. It's an automatic response. But if you have a lesion in your cord from MS, sometimes those get a little bit messed up. And so you might actually be hot. Your body, it might be 95 degrees outside, but you might actually be cold because your body is misinterpreting the information. So you'll see people with MS that they're, in jackets and it's like 90 degrees outside and they're really, and you go and you touch them and they're actually cold. So it's kind of a weird thing. And I often see people with MS, they have really, really cold feet. And they'll come in and say, I feel like my feet are ice. And it's 110 degrees outside in the summer. And you touch their feet and they are very cold. And that's, again, because of a disconnect. The body isn't receiving that information correctly, so it's overcompensating in the wrong way, making those feet actually colder by clamping down on the arteries. Does that make sense? So it might be that that's the reason why hot or cold is better for, say, your daughter. So I wouldn't, but I would say that generally speaking, I would choose where you live based on where your family and your friends are. And then, if they happen to live in Siberia, buy a really good coat. You know what I mean? Like,
so cold weather is not.
It's not damaging.
Good for.
It's not, well, the cold weather isn't damaging and neither is hot weather. It's not damaging, it just can make your symptoms worse, right? We often think of cold weather as being bad in MS because the further away from the equator you get, the more likely you are to get MS. But we think a lot of that has to do with vitamin D deficiency. So as long as you're taking your vitamin D, you should be okay, in theory. So that, that's, but I don't think cold is damaging to MS any more than, say, heat is, right? But if she can afford to live in, say, like, Malibu, I say go for it, right? When it comes to sleep disorders, I just want to talk a little bit about sleep disorders. We'll kind of jump through a little bit of these. But again, there's a lot of things that cause sleep disorder, things like poor sleep hygiene. So just so you guys know, there's only 2 things you're allowed to do in bed, sleep and the other thing you do in bed. And other than that, nothing else. That's it. So sleep and sex. Anything else you should not be doing in your bed. You shouldn't be reading, you shouldn't be on your iPod, you shouldn't be doing your Kindle, you shouldn't be watching TV, because all of that is training your brain to stay awake in bed. And what you want is like a total Pavlovian response that the second your head hits that pillow, down. And we all know these kinds of people, but actually we call it sleep hygiene. Keeping your habits clean in the bed, right? And if you can do that, people do much, much better. Having a schedule, like I said, I have a 1-year-old at home, and as an adult teaching a child, we all know that this routine is very important for children, but as an adult, somehow we become stupid and we forget that. And we we go to bed at 2 on Friday, and then we try to wake up at 6 in the morning on Monday and be ready for work, and this is why Starbucks makes a fortune, right? So pain, also nocturia, medications, you have to take a look at that, psychiatric illness. But then I want to talk about these last 4, sleep disordered breathing and these kinds of things. I want to show this one study. This was a goofy thing. They took 66 people with MS that were referred to a sleep study center, and they just took a look at them. And what they found out was that 74% of them had an identifiable cause for their fatigue. So 3 out of 4 had a problem that they found on the study, okay? So 26% didn't, and this kind of breaks it down, but these guys all had a problem that you could identify. When divided up by this, afterwards they divided them up by this fatigue score. So when they actually came in, they took that test, that MFIS, like that big long one, and everybody who scored in a positive range, 96% of them had an identifiable sleep disorder on the study, okay? 60% didn't. And the fatigue was associated with sleep disorders in a very, very significant way. So this is, I think, the way you can think about it. Fatigue, so you have the MS going on, and you have all these other things that can completely mess up your sleep, okay? And that's going to cause sleep fragmentation. You're not going to be able to get up, and you're waking up every 90 minutes. And we should really throw in there 1-year-olds too, because that's a problem. But spasticity and anxiety and bladder dysfunction, all these things, they can really mess with your sleep. And that's going to make you tired. But there's also this one, sleep disordered breathing. And you guys all know, like, there's somebody in here, I'm sure, sleeps with somebody who sounds like that at night, right? Or you are that person. And so we're going to talk a little bit about that. Fix what can be fixed. This is something we can do something about, okay? So in a follow-up study, just to drive that point home, those same 66 people, when they tracked them 2 years later, what they found was that if they had an identifiable sleep disorder and they treated it, their fatigue score went way down. So just treating that sleep thing really helps fatigue. So the take-home point for me talking to other doctors is diagnose the sleep disorder, treat it, fatigue gets better, patient happy, right? So that's the key. And that's been replicated in other studies as well. So obstructive sleep apnea It's increasing in prevalence. It's associated with large body size. It's associated with high blood pressure, heart failure, arrhythmia, diabetes. It causes all kinds of problems and is associated with all kinds of problems. And this is what you look for. If you're getting a headache every time you wake up in the morning, if you're a big person, if you have sleepiness in the morning, if you're snoring, that's actually not as specific and sensitive as you'd like it to be. It's that gasping, choking for air, that kind of a thing, and people wake up in the middle of the night. If you hear that in somebody you love or your partner, make them go get a sleep study, because that's something we can fix. So I'm going to jump through there. So this, actually I got the wrong picture in there. Yeah, this is, sorry, I apologize. This is a picture of central sleep apnea, not obstructive sleep apnea, I apologize. So in this one, what you're going to see is this. See that little part that says where it says Eeg Arousal? So these are brain waves up here on the top. And you see they get really kind of spiky up there? That's not the correct term, but anyway, you start to see more activity there. That's because they woke up. And what you're looking at here is airflow. So see these little green up and down kind of things there? When you see those big green things, that's breaths. That's them breathing. What you'll notice is there's a flat line before that. There's no airflow. And one of the things you'll see here is that this is your chest wall, and here this chest wall is not moving. So that is central sleep apnea. So that means something in their brain isn't even telling them to breathe. They're just laying there, they're not breathing, and then all of a sudden, and they kind of wake up. So that's a different issue. In obstructive sleep apnea, it looks exactly the same, except there's waves here on the chest wall. The chest is actually trying to expand, but there's a blockage, and it can't wake up, it can't get air, and then it wakes you up, and then you open up, and then you breathe. And you do that all night long. Imagine how exhausting that is, right? So you're trying to take a breath, trying to take a breath, trying to take a breath, can't get a breath, and then your brain says, wake up. You wake up, and then you go, and then you go back to sleep. And you probably don't even know you're waking up. And people will do this 10, 20, 30 times an hour. I mean, exhausting. They're just not getting any rest, right? So this is a kind that you'll see in people who have heart failure. It's called chain Stokes breathing. You get this sort of crescendo, decrescendo breathing pattern, and then a pause. No breathing, odd breathing. No breathing, odd breathing. And every time up here, you can see that they're waking up, waking up, waking up. They're just not sleeping well. So these guys are exhausted. This is an even weirder one. I mean, there's a lot of reasons to not use narcotics, but this is one. Narcotics can actually induce centralized sleep apnea. So central sleep apnea, it can actually decrease the drive to breathe to the point where people just lay there, don't breathe, and then do that all night long. So then they're constantly exhausted. So, I mean, narcotics will make you sleepy anyway, but this is another reason. So this was somebody who came in, had sleep apnea. So each one of these little gray boxes is a period where they weren't breathing, right? Or this is where they woke up. And here's where these little gray boxes are, they're not breathing, not breathing, not breathing, not breathing. And those are like 10-second gaps, 10 seconds of no breath. 10 seconds of no breath, wake up, breathe. 10 seconds of no breath, wake up, breathe. It's terrible. But when you drop this person's narcotic dose, much, much, much less, and the person's fatigue is much better. So we try really hard not to give narcotics out. And as a general rule, I just generally don't do it much in my practice at all. This whole point of this slide is basically to say, so forget about it because it's really kind of jargony here, but people with MS are more likely to have central sleep apnea and obstructive sleep apnea. That's the key. It's a more common finding in MS patients than in the average population. And what's weird about it is that central sleep apnea is linked to certain lesions. So this is a brain MRI, and one of the things you'll see there, I don't know if you can see, I'm going to have to walk around here again, is this right here. See this white part right here? That shouldn't be there, and that's the pons, that's the part of the brainstem that attaches to the balance center, essentially. And if you get lesions there, you tend to be more likely to get central sleep apnea. So that is actually a direct correlation, and at least why we think in MS, these people tend to have sleep apnea a little bit more. So you can see that big arrow there, right there. Another one is this one. It's called Restless Leg Syndrome. You guys have probably heard about this on the TV. You hear about it all the time on the TV. It's a little bit overdiagnosed on the TV. But the thing is this, it's 5 to 10% of the general population, but there was this great study in Italy, and they showed that up to almost 37.5% of people with MS. I mean, it's a lot more prevalent in MS. Now, there's no imaging pattern that fits with it, but this is it's important to, let me just talk about what this is. It's an urge to move the legs. If you're laying in bed and your leg just goes and it jerks off, that is not restless leg syndrome. That is a different thing. And you treat it very differently. But if you're laying in bed and you think, oh my gosh, and it's almost like you have this need to get up and move your legs, and then you get up and you move your legs, that's restless leg syndrome. It's almost always at night, or at least it's much worse at night. It usually gets worse when you're doing rest or inactivity. They're usually partially or totally relieved by movements. So once you get up and move around, it's almost like scratching an itch. You're just like, okay, now I feel better. And the problem is it keeps the person awake, okay? So, and this is sort of a nice little tip. If the patient has restless leg syndrome, they're going to tell you about it. If their legs are bouncing around in the bed, their partner is going to tell you about it, right? So if you're getting woken up and like your loved one is sitting there kicking you all night long and they're not even aware of it, it might be a different problem altogether. That you would treat actually with things like Valium. This you would treat with a lot of other different medications. But this is an interesting thing too. The more disabled a person is with MS, the more likely are they have this problem. So EDSS is the way we score disability. So just to give you a frame of reference, a 3 is like somebody who has a hard time standing because their balance is off. A 6 is somebody who needs a cane. 4 can be blindness in an eye. 7.5 is someone who needs a walker. And 8 to 8.5 is someone who's wheelchair bound. So it's on that scale. So you get up to like the people who need canes and walkers, they're more likely to have this particular problem. This is another way of describing it. And what they showed in this one, is that if you look at that first bar there, that first tall thing there, that's saying, again, that there's a difference between people, the higher the score is, people with an average of 3.5 on the scale tended to be much more likely to have this restless leg syndrome than people at an average of 2.5. But what they also said is that if you see where those little stars are, so I apologize, I don't have this little marker. Here, these are people with motor symptoms. Pyramidal means motor. So people who can't move their leg because of weakness, they tend to have it more often. And also people who have more numbness and tingling, that last one. So people who have a lot of numbness and tingling in the legs or a lot of that kind of thing, they also will tend to have this a little bit more commonly. But you have to remember, like I said, there are other things that can mimic this. Leg cramps, fibromyalgia will lead to a lot of pain and that kind of thing that will make you want to move your legs around. Peripheral neuropathy, leg edema, even veins that are kind of static there and you're not draining your veins real well. All that can give you a similar kind of a feel, so you have to take a look at it and see. But restless leg syndrome is something that does happen. It seems to happen more in MS. So the way you check, another thing to check is that iron deficiency, believe it or not, is something that can cause this. So you have to check for iron deficiency, especially if you think of like young women. So if you're like a young woman and you have this, you got to check for iron deficiency because young women tend to get that a lot anyway. For like menorrhagia, people have like really heavy menstrual cycles and that sort of thing. So this is the weird thing. I'm not going to get into too much of this. These are all medicines that are approved or used, all these ones right here, for the treatment of restless leg syndrome. And whether or not one is better than another in MS, I really have no idea. I don't think we've ever done that study. But a lot of these people are on. Gabapentin is Neurontin, pregabalin is Lyrica, Zolpidem is Ambien, believe it or not, clonazepam is Klonopin. The funny thing about this is, and this is not funny but sad, all these will make you very tired, right? So these are medicines that will treat your sleep disorder but also make you tired, which is a problem, right? So the last one I want to talk about is this thing. It's called REM behavior sleep disorder. Anybody who has any loved one with Parkinson's probably is a little bit more familiar with this. It's associated with lots of different diseases, including MS, Parkinson's, MSA, dementia with Lewy bodies. A lot of the things we see in this building are associated with this problem. But essentially what it is it's an inability to paralyze your body when you sleep. So what you do is you act out your dream. Most of us, when we are about to fall asleep, there's something in our body that just sort of shuts off, and then our body just kind of lays limp as we dream. But in these people, that's shut off, so they'll act out their dreams. Sometimes they'll beat up their pillows. I put this thing up here on the top because there's a comedian whom I think he's fantastic. And his name is Mike Birbiglia, and he made a movie because he has REM behavior disorder. So he talks very candidly in this movie about his disorder, and he actually videotapes himself sleeping, which is terrifying to see what he goes through every night. But he's a comedian because he kind of uses his tragedies and his problems to make people laugh. And if you're curious about what this is, it's an interesting movie just because it's just to see this guy. And in his story, he actually had this dream once where he was being targeted by the Russians and they were going to blow him up. And in his dream, he decided he had to jump and run and dive out the window to save everyone else in the building because he was about to be blown up. And then he woke up actually having jumped out of a second story of a hotel, bashed through the windows, all cut up, and he had run halfway across a field. It was like a Holiday Inn. So it's tragic and terrible, but that was his story, and that's what REM behavior disorder can do in severe cases. Luckily, it's not more common in MS than it is in the regular population, and it's luckily very rare. But if you do see it in MS, it usually, again, is due to lesions in the pons. There's something about the pons that is really important. So this area right here, I don't think right there, that little area there with the white spot, if you have lesions there, you tend to get this thing in MS if you're going to get it. So if you ever have somebody giving you this story and they have MS, most of us as neurologists don't associate the two. And so if somebody told me that story, I'd think, this can't be right. But it turns out it can be in this setting, because we usually associate it more with like the Parkinson's type stories. So this is more geared towards docs, but if you ever do hear about this, and if you're curious and you want to see what I'm talking about, rent that movie. It's on Netflix if you want to do that. But it's an interesting one because it's kind of amazing to see what your body can do when something that small goes wrong. So the last thing I want to talk about is just this. It's just a list of medications. And these are medicines that we use almost daily in an MS clinic. And every one of them is going to have problems with sleep. So when you're thinking about fatigue, you have to kind of go through that list and say, well, shoot, how is this affected? And how is this making my life a little bit worse or a little bit better? And mostly you just want to go through the list and think, well, okay. And if you have like, say, 3 possible things on this list, don't stop them all at once. Then you don't know which one's the problem. Stop one, do okay, stop the next one, then see what is the actual issue causing your sleep problem. So lastly, recognize that it's an issue. Address any secondary causes. There are things that you can fix, so fix those. There's no silver bullet. The medicine that is most commonly used is modafinil, but it's very much off-label. And there are some medicinal approaches that are worth thinking about. Conservation management, maybe go visit a urologist, exercise therapy. And then also, you know what? It's okay. If your doctor says, I think you have a sleep problem, you're like, I don't want to do a sleep study. Just go do it. Because you know what? If you have fatigue and you get referred over there, 75% of them have a problem that we can identify and then fix. And that's what we're trying to do anyway, right? So that's the key at the end, is fix what can be fixed. And if you do that, you'll feel better. And we can't get rid of it all, but maybe we can make it better and make your life a little better. So that's my story.